So today we will be talking about a new molecule or just simplifying or even with innovation or even bettering the management of diabetes and in the context of risk reduction in various ways. So we are always looking for an ideal anti-diabetic drug because we still have not achieved whatever we want. So now we will look at a new era of how we can give a peptide in a pill which was never possible in the past. So what's wrong in this picture? So you can see that our quest for treating diabetes started way back. It started with insulin, then in 60s with sulfonylureas, then we had metformin. But as of 2005, we have almost about 40 new treatment options for diabetes. And in spite of all these options, what we can see here is that people who have achieved HbA1c below 7% is only 23.4. So 3/4 of the people who, in spite of so many treatment options, have their HbA1c above 7%. So obviously, despite these available treatments, diabetes remains the 9th major cause of death globally. 50% of patients with diabetes present with microvascular complication, 27% with macrovascular complication, and 25% have diabetic kidney disease. When we say that we want an ideal anti-diabetic drug, we are trying to balance various things. On one side, we have a desire to control or lower the blood glucose, but at the same time, we don't want hypoglycemia episodes to happen. We want to control the weight gain or if possible, want a weight loss, but at the same time, we don't want off-target effects, and we want obviously a better HbA1c. So our expectations from a new anti-diabetic drug is that it gives good glycemic control, smooth control with low risk of hypoglycemia. And it should cause weight loss or at least no weight gain. So it should be weight neutral if not losing weight. And there should be minimal off-target effects. And our HbA1c should be below 7. So these are the ideal features. Now, if you look at all the available options or classes of anti-diabetic drugs, we will not go into the details of all classes in terms of their every property, but let's look at important things. We just discussed about the hypoglycemia risk. So a lot of molecules, inclusive of GLP-1 have low risk of hypoglycemia. The efficacy for reduction of HbA1c is good in some molecules. It is very good. It is very high in GLP-1 the weight effect, you can see that the green arrows or the downward arrows are only in two options. That is the SGLT2 inhibitors and the GLP-1 More importantly, the cardiovascular benefits. So not only they are neutral, that means there is no increase in risk as in some of the other molecules, but there is actually cardiovascular risk reduction, which is one of the most important things. So if you look at this orange part of the diagram, you can see that GLP-1 provide kind of fulfill our every wish list that we have with an anti-diabetic drug. So there are various effects, and without going into these details of this slide, that this addresses 6 out of the 8 octet mechanisms. So other perspective in taking an anti-diabetic medication is patient convenience. And what do patients prefer? Do they prefer to take a violent syringe, whether it is insulin, whether it is some of the other injectable things like liraglutide, even with, so vial and syringe is probably modified by the pens, which is slightly better. But obviously, everyone would prefer a tablet form. So this question is purely rhetorical. There is no sort of great science behind this, that everybody would prefer a simpler method of administration. But if you want to administer a peptide orally, then the problem is that it undergoes degradation in the stomach due to the low pH and due to proteolytic enzymes. And this enzymatic degradation is also further increased or is further troubled by the limited permeability across the GI epithelium. So there is a very low oral bioavailability. So if you administer a GLP-1 RA alone orally, then its bioavailability would be less than 0.01%. So it is something like 1 in 10,000 part will actually be available inside the body. So this issue of limited absorption till now was one of the major concerns. Semaglutide is a molecule which has a 90% homology to human GLP-1. So it has certain these things like the spacer and C18 fatty acid chains to lysine, which causes strong binding to albumin. It has a very long half-life of about a week. And then you have these other substitutions of amino acid, which protect against DP4 degradation, and also the C18 fatty diacid binding at the wrong side. So these minor substitutions from the natural molecule kind of help in creating a drug option. So how do we overcome this issue that we have a very good peptide molecule in the form of semaglutide, but now how do we give it in a pill? So we have something called an absorption enhancer. It is called SNAC, or sodium N-aminocaprylate. It is also known as salcaprosate sodium. It's a small fatty acid derivative that promotes the absorption across the gastric epithelium, and by itself it is metabolized by beta oxidation and glucuronidation and eliminated through urine. This co-formulation does not change the chemical structure of any of the molecules. So there are two different entities just kind of bundled together. So it protects SNAC protects the semaglutide molecule and helps in getting it absorbed. So it get it absorbed from the stomach, and therefore better transportation through the gastric epithelium, and the degradation with gastric enzyme is prevented. So this is the GLP-1 analog semaglutide. It has a very long half-life. It's a very effective molecule. And then we combine it with this SNAC, which promotes the absorption through the gastric epithelium, enhances the availability. And therefore now, just by joining these two in a single tablet, it would be possible to have a better bioavailability. So it basically increases the absorption because of this co-formulation. It causes a local increase in pH, which leads to higher solubility and protection from proteolytic degradation. So basically, this is a strictly time and concentration dependent mechanism, and it is fully reversible. So it doesn't mean that the pH in the stomach would remain changed. And it is also happening very locally, but it will not remain changed for a very long time or something. So it's not going to alter your normal GI mechanisms. And approximately 1% of semaglutide is absorbed. So even now it is 1%, but remember previously it was 0.01%. So the absorption is now significantly increased. So we know that we need an ideal anti-diabetic drug. Peptides are challenging compounds, and therefore they can't be easily given through oral route. Although semaglutide is a good GLP-1 RA molecule with a long half-life, but it needs a co-formulation with snack. So the mechanisms of absorption is compound specific, transcellular, and without any effect on tight junctions. So this concept of peptide in a pill or oral peptide or oral semaglutide is not only just an advance for diabetes or for semaglutide, but it will open an entirely new chapter in the administration of peptides given orally. Thank you.